Bismillahirrahmanirrahim. Let's discuss amyloidosis. Amyloidosis is a condition associated with a number of inherited inflammatory disorders in which extracellular deposits of fibrillar protein are responsible for tissue damage and functional compromise. In the start, it was thought that it resembled the starch, therefore the deposits were called as amyloid, a name that is firmly entrenched despite the realization that the deposition are unrelated to starch. While discussing about the pathogenesis, first we will discuss that amyloidosis is fundamentally a disorder of protein misfolding. The dye congarite is used, and when it is used, it binds to these fibrils and produces a red-green dichorism. Basically, misfolded proteins are degraded intracellularly in proteasomes or extracellular by macrophages. When they are not degraded, as a result of that, misfolded proteins are produced, and then these monomers assemble to form the beta sheet structure that is called fibril. The second category is amyloid light chain protein. The amyloid light chain protein is produced by plasma cell and is made up of complete immunoglobulin light chain. Defective degradation has also been involved as the basis of fibril formation, and perhaps particular light chains are resistant to complete proteolysis. As a result of their limited proteolysis, AL proteins are produced. Amyloid-associated fibril proteins occur as a result of chronic inflammation. When chronic inflammation occurs, macrophages are activated. These macrophages produce interleukin-1 and interleukin-6 in the liver cells, and as a result of that, serum precursor called as SSA protein is synthesized in the liver. When that protein shows limited proteolysis, as a result of that, AA protein is produced. People who develop amyloidosis have an enzyme defect that results in incomplete breakdown of SSA, thus generating insoluble AA molecules. You may say that another factor is genetically determined structure abnormality in the SSA that lead to this limited proteolysis. Third category is A-beta amyloid that is found in the cerebral lesion of Alzheimer's disease. It constitutes the core of cerebral plaques and is a much larger transmembrane glycoprotein called as amyloid precursor protein. Transthyretin is a normal serum protein that binds and transports tyrosine and retinol, hence the name. When mutation occurs, as a result of that, mutant transthyretin is produced that aggregates to form ATTR protein. Disorder are called as familial amyloid polyneuropathies, and TTR is also deposited in the heart of aged people called senile systemic amyloidosis. B2 microglobulin, it is a component of MHC class 1 molecule and a normal serum protein. It is present in high concentration in serum of patients with renal diseases and is retained in the circulation because it is not effectively filtered through the dialysis membrane. Amyloid deposits derived from diverse precursors such as hormones, procalcitonin and keratin have also been reported. Let's discuss about the classification of amyloidosis. It involves the systemic rejection, hereditary amyloidosis, and localized. In systemic amyloidosis, the first class is immunocyte dyskaryosis with amyloidosis. It is systemic. In US, it is the most common form. AL type, multiple myeloma, monoclonal plasma cell proliferation. Now what happened in this? The multiple myeloma will show the plasma cell tumor that would be characterized by multiple osteolytic regions throughout the skeletal system. As it involves a multiple myeloma, and M myeloma protein spikes will also be shown. And while talking about the chemically related precursor protein, in this case is the lambda kappa light chains, also called Benson protein, that will appear in urine. The appearance of this in urine depend upon the amyloidogenic potential, and it influences the deposition of Benson protein. That is a type of light chains produced after its catabolism. So basically this is involved in amyloidogenic potential. Reactive systemic amyloidosis is an amyloid association protein secondary to an associated inflammatory condition, and tuberculosis, bronchiectasis, chronic osteomyelitis, they were the most common causes with the advent of effective antimicrobial therapy. Along with that, diseases Patient also show chronic inflammation caused by autoimmune states, for example, rheumatoid arthritis, inflammatory diseases. Skin popping of the cortex is also seen. Tumors may also be seen, like tumors, for example, renal cell carcinoma or Hodgkin lymphoma. They are not derived from immune cells, these tumors. Hemodialysis-associated amyloidosis include A beta 2M type, chronic renal failure is the associated disease with it, and the chemically related precursor protein is beta 2 microglobulin. While talking about the hereditary amyloidosis, the familial Mediterranean fever is the autosomal recessive condition that causes fever and then inflammation of serosal surface. Amyloid associated protein and SSR are involved. What happened in this? There is a gene called pyrin that is a component of the inflosome, and this pyrin, there occur mutation. As a result of that, it results in constitutive overproduction of the pro-inflammatory cytokine interleukin 1 and persistent inflammation. While talking about the autosomal dominant familial disorders involved in hereditary amyloidosis are familial amyloid neuropathies and systemic senile amyloidosis. That include the ATTR, major fibril protein, and chemically related precursor protein called as transthyretin, TTR. Let's discuss the last type, that is called localized amyloidosis. In it, nodular deposits of amyloid, for example in lung, larynx, skin, urinary bladder, tongue, and around eye is seen. It includes AL protein. It is of three types basically. One is called senile cerebral, that involves Alzheimer's disease, EB and EPP type protein involved. When talking about the endocrine, these deposits are found in certain endocrine tumors such as medullary carcinoma of thyroid gland, islet tumor of pancreas, pheochromocytoma, undifferentiated carcinoma of stomach, as well as in the islets of Langerhans in patients with type 2 diabetes mellitus. The third type is isolated arterial amyloidosis that involves the type 2 diabetes mellitus, and ANF is involved in it. Let's talk about its morphology. When painted with iodine and H2SO4, you may see it shows brown staining. Large amount of cell appear gray, waxy, or firm. Most of the amyloid deposition are extracellular and begin between the cells, and they are present adjacent to the basement membrane. That was the histopathological findings. The dye which we use is called Congo dye. Let's talk about its morphology in different organs. In kidneys, it is most common, most serious, found principally in glomeruli, but then may move towards the interstitial peritubular tissues, as well in the wall of the blood vessels. Total obliteration of vascular tuft and amorphous pink cast are also seen. In spleen, spleen enlargement is seen, almost 200 to 800 gram. Splenic follicle, zygospleen, large sheet-like deposits. The audacious spleen is also seen. In liver, enlargement, and along with that waxy appearance. It first appears in space of Deci, then involves the hepatic parenchyma and sinusoids. Atrophy may also be seen. In liver, it appears in two forms, isolated and systemic. Isolated occur in old person, systemic form is AL, and deposits are present between the myocardial fibers. Other organs are also affected, for example, adrenals, thyroid, and pituitary are the common sites. In tongue, it causes macroglacia and deposition of beta 2 microglobulin in patient receiving long-term dialysis occur, causing carpal ligament of the wrist, and that will obviously result in compression of median nerve, leading to carpal tunnel syndrome. In clinical course, non-specific complaints such as weakness, fatigue, and weight loss is seen. Renal diseases, hepatosplenomegaly, cardiac abnormalities, where proteinuria is seen. For diagnosis, biopsy, and subsequent concurrent staining, electrophoresis, immunoelectrophoresis, bone marrow examination, and along with that proteomic analysis done. Patients with myeloma associated amyloids have poor prognosis, and that's all.